let's start with the anatomy of eye. As I said, the anatomy of eye is the basic part that we should understand first, and only based on that we will be able to read everything moving forward. Okay? My eye is a ball, everybody. Yes, my eye is a three-dimensional structure. The first question that I like to ask always to students is, what is the shape of my eyeball? Does my eyeball to you look like a spherical object or an aspherical object? Spherical means, does it look like a cricket ball? Or aspherical means, does it look like a rugby ball? So what is the shape of my eyeball? If you are saying it looks like a cricket ball, sir, then you are wrong. Yes, it does look circular or spherical, but it is slightly aspherical. Please remember, it is not spherical, it is aspherical. And what is the aspherical shape if we want to answer? The answer is oblate spheroid. Okay, that's the name of the shape, oblate spheroid. Now, very basic questions, everybody. What is the volume of eyeball? It is a 3D structure, so it should have some volume. So the volume of eyeball is 6 ml. The volume of eyeball is 6 ml. What is the length of eyeball? The length of the eyeball, also known as the axial length, also known as the anteroposterior diameter, is 24 millimeters, or if we do simple maths, we can say 2.4 centimeters. Now comes the question, where is my eyeball situated? So all of us know, just looking at my eye, everybody, if this is my eye, the eyeball is situated within a bony cage. Yes. And what is this bony cage known as, everybody? This bony cage is known as orbit. Yes. Orbit has 4 walls. We have studied in anatomy, probably even in ENT. This is called the roof. This is called the floor. This is called the lateral wall. And this is called the medial wall of orbit. So as soon as we see this image, guys, I hope we understand what I am trying to say. This is my eyeball, and this is my bony structure, everybody, or the bony cage, and this is my orbit. So the orbit is providing a protective case or a protective house, everybody, to my eyeball. Yes. Now, once we understand this, everybody, let us try to understand in detail, everybody, what are the structure or what is the layers of the eyeball, everybody. Okay. So to understand this, think as if your eyeball is an orange. Now, when we peel an orange, everybody, we have to peel 3 layers before we end up eating the fruit. First of all, we are peeling that outermost orange thick layer, everybody. Outermost, because that is the first layer we are able to touch and see. Yes. Once we have peeled that orange layer, everybody, we see a fibrous mesh-like layer, everybody, jali type layer, which we remove. Then we see a translucent coat. We open that translucent coat on each slice, and we are able to eat the orange pulp or the fruit orange. Yes. So that means I can say, if I compare my eyeball to an orange, I have 3 layers. What are the 3 layers, everybody? The outermost layer, the middle layer, the jali, the middle layer, and the fibrous or the translucent layer, that is the innermost layer. So similar to an orange, my eyeball has 3 layers: outermost, middle, and innermost. Outermost layer, middle layer, or the innermost layer or the inner layer of the eyeball. Yes. Now, outermost layer is very easy to understand. When you're looking at my eye, everybody focus at my eye. Now that you're looking at my eye, everybody, which layer are you able to see? Can you see the inside layer? No. The first structure that you will be able to see, or the first layer which you will be able to see, has to be the outer layer. Okay. So now if you focus looking at my eye or anybody else's eye, or for that matter your own eye, everybody, if you're looking into a mirror, you will be able to see that we see basically 2 parts or 2 regions. One is the central circular blackish or brownish part that we see, and in the periphery we are able to see a white structure. Common sense tells us that means it should have 2 parts, the outermost layer, the white part and the central black or brown part. Yes. So that is my question to all of you now. Basic anatomy, you have read it in first year also. If you're a post intern, you already know, you should know rather. If I get a photograph with an arrow touching the white area, everybody pointing to the white area, and they are asking to identify the white area. What is the white area? What is the white area? Can you identify, can you name the white area, one part of the outermost layer? If you are saying conjunctiva, you are wrong. But if you are saying sclera, then you are absolutely right. Okay? Now, what is the central part, everybody? What is the central part? Are you saying iris? Iris? No. Pupil? Pupil? No. No. Cornea, sir. Cornea. Yes, cornea. So there are three options. Yes, these are the three options. This is what students who don't understand the anatomy keep getting confused in, everybody. Is the central part that you see here, everybody, the black part, the brown part, is it the cornea? Is it the iris or is it the pupil? Is it? It is the cornea. Yes, it is the cornea. Yes. Now, let us try to see this anatomy through a model. Everybody, let's focus on the three-dimensional model of the eye. In this three-dimensional model, what are we able to see? We are able to see that in the central part, there is a clear, transparent structure. Whereas in the periphery, everybody, there is a blue-colored structure. This blue-colored structure is what is visible to as white color. Yes? So, that means this central part that we are seeing, this is my cornea. Now, why does my cornea or your cornea look black and brown in color, everybody? If you are able to see behind the cornea, everybody, there is a brown colored structure. Yes, that is your iris. In the center of the iris, everybody, there is an aperture. There is an empty area which is appearing black in color. That is your pupil. Because your cornea, everybody, is transparent, that is why you are able to see the structures behind it. And that is why in a normal eye, what is visible to you is a brown or black colored cornea. So now I hope we understand that the central part is our cornea and cornea is transparent. The peripheral part, which is the sclera, everybody, see peripheral part, why am I saying? If you see the front view, it is visible to you and it is extending posteriorly. Everybody, you see the whole posterior part of the eyeball, outermost layer is covered by your sclera. I hope you have been able to understand this. Now, what do we see on sclera? We see on sclera, because it is the outermost layer, the extraocular muscles are inserted onto it. You can see, everybody, this is the extraocular muscle, lateral medial rectus, superior rectus, everybody. Yes, so the extraocular muscles are inserted onto the sclera. Also, there is a third part to the outermost layer. The junction of the cornea and sclera. See, it's this whole junction, everybody, or if you look at my eye, everybody, the junction of the black part, visible black part, it is transparent, I know, but I'm saying it black because it is visible to you, black or brown color. We are Asians, we have a dark brown iris. Yes, so the junction of the cornea and sclera, the black and white, everybody, the junction, that is the third part, and that third part is known as, yes, everybody, limbus corneo-scleral junction. Okay, now what about the second layer, everybody? Obviously, once we cut the outermost layer, then we are able to see the second layer. Now if we see here, everybody, see in this part, you are able to see all the three layers. The blue layer is the outermost layer, then this red layer, everybody, is the middle layer because we have cut or removed the outermost layer, and then if we cut even the middle layer, we are able to see the yellow colored inner layer. So now my question to all of you, what is the middle layer of the eyeball known as? Middle layer of the eyeball is known as, some of you are saying choroid. Choroid is the wrong answer. Choroid is the wrong answer. Yes, some of you are saying uvea. Uvea is the right answer. Choroid is just one part of the uvea. Let me make you understand what is the middle layer. So I'm going to open it from top, everybody. Let's say we have dissected the eyeball. Okay. Now, let me remove the outermost cornea. So now what do we see? The middle layer. What do we see the middle layer, everybody? We see anteriorly first structure, that is your iris. When I remove the outermost layer, I am touching or I am seeing the middle layer. I am seeing the iris. Yes, anterior part. Now, along with the iris, in the periphery, I am able to see everybody's ciliary body. You see this thick red colored part? This is the ciliary body. And as we move back, this keeps on becoming thinner, becomes a very thin line surrounding 360 degree the whole eye, everybody. See on this side also, red colored ciliary body. And as we go back, it becomes our choroid. That means the middle layer has three parts. Anteriorly your iris, then intermediate your ciliary body, and then posteriorly you move and you get your choroid. If you want to see, let's see it like this: iris, ciliary body, and also choroid. Now, when I will remove my iris, I will be able to see my lens. Okay? Lens is not a part of any layer, everybody. It is just a structure. And we see that the lens is attached by some thread-like structures, everybody. Yes, you see these thread-like structures, 360 degree. These are my ciliary zonules. So if we see carefully, this is our lens, everybody. And throughout 360 degree, everybody, this lens has some zonules. These are the zonules, everybody, which is enabling the lens to be suspended in the center of the eye. Now, once I remove this, everybody, let me also remove this. I'll get back to it later. What am I able to see? I am able to see the whole yellow area, everybody. This is the innermost layer of the eyeball. Okay, so moving from anterior to posterior, what did we have? First of all, we had the cornea. Yes. Then everybody, we had the middle layer, that is the iris. Then if I forget the lens, everybody, we have the inner layer, that is my retina. In retina, we can see the blood vessels, everybody. We can see the retinal artery, red color. We can say the retinal vein and its branches, blue in color. We can see all these arteries and veins are originating at one point. Yes. What is this one point, everybody? This is your optic nerve, or this is your optic disc, I can say. Okay. The central retinal artery or the central retinal vein, they enter our eye through this optic nerve or the optic disc, everybody. Yes. I hope we are clear about the basic anatomy. Now, what is this, everybody? So this huge part, everybody, is filling the space, the posterior space of the eyeball. And this is a gel-like structure which is called as vitreous. Okay. To be able to understand again the eye. Okay. Let me show you this cut section again, everybody. This cut section shows three layers: outermost layer, middle layer, and the innermost layer. Outermost layer has two parts: cornea and sclera. Middle layer called uvea, everybody. Uvea vascular layer, three parts: iris, ciliary body, and choroid. And the innermost layer is known as retina. If I see it from inside, everybody, this whole yellow colored part is my retina. This black colored thing that you see here, it is an extension of the ciliary body, everybody. Yes, that is what we will discuss moving further on. I hope through this 3D structure, you have been able to understand maybe a little bit of the anatomy. Now, let's write what we have discussed here, everybody. The middle layer was known as uvea. Uvea had how many parts, guys? Three parts: iris, ciliary body, and choroid. Whereas the inner layer, everybody, is known as we saw yellow colored layer in our model, retina. Okay. If we talk about the basic functions of each layer, the outer coat or the outer layer can be called as the fibrous coat. The middle uvea is called the vascular layer, and the inner retina is known as the neural layer. So the outermost layer, basically the sclera, the major part, everybody, this is serving your function of protection, fibrous coat. The middle layer is giving you blood vessels, and the inner layer is giving you vision because it is the neural component. Now, to have our anatomy better fixed in our minds, we will be drawing a diagram, a cut section diagram, and along with that, we will be correlating the 3D model that we have seen here. Let us draw the diagram, everybody. Along with me, everybody. See, first of all, I am using a red colored pen to draw. I am using red color to denote the fact that I am drawing the vascular layer of the eyeball here. Okay. So this is the red colored vascular layer or the middle layer of the eyeball that I have drawn. I am using a black colored pen to draw the outermost layer. And lastly, I am using a yellow colored line to indicate the inner layer that I am drawing. Okay. I hope you are able to draw with me, everybody. Yes. Then we know that we have a structure suspended in the center of the eye. That is the lens. And as we saw, this lens has some thread-like projections or fibers attached to it. That is what we have drawn. I hope, guys, you have been able to draw the diagram along with me. If yes, everybody, let's start labeling it. Let's start from the outermost layer. The anterior part of the outermost layer, which is convex. See the two clues: anterior part, outermost layer, convex. This is your cornea. Obviously, this is your cornea. Okay. Now, the posterior part, which is opaque, white in color here, everybody, is your sclera. Yes or no? In my eye, you can see white color. In the 3D model, we had seen blue color completely encircling, encompassing the whole structure of the eye. And at the junction, everybody, we had said corneoscleral junction was called as limbus. So we know that these three are parts of our outermost layer of the eyeball. Okay. Now, if we remove the cornea, we are able to see this. Think about that. If we remove the cornea, we are able to see the middle layer. The anterior portion of the middle layer with a hole in the center or an aperture in the center. The aperture was called as pupil. And the part of the middle layer was called as iris. Okay. Now, behind the iris, the second part, everybody, that we saw is named as ciliary body. Okay. Now, focus on ciliary body. Ciliary body I will further divide into two parts. Okay. What are the two parts? One part I have marked with a lot of dots. The other part I have marked with the cross lines. These are two parts based on the anatomic appearance and their functions. Let me describe the first part of ciliary body with the dots in it. I say that when I look at the cut section diagram of my ciliary body, the anterior part of the ciliary body looks as if it has some folds in it. Okay. Or I can say it has some finger-like projections in it. Okay. These finger-like projections can be called as plicae. Yes, higher dermatology plicae, everybody. So I am saying this part of my ciliary body can be called as pars plicata. Pars plicata because I am saying it has some plicae, some finger or hair-like projections in it. I hope I am clear. But when I look at the second part of the ciliary body, the posterior part of the ciliary body, I say there are no finger-like projections, there are no folds, there are no plicae. It is just a flat or a plain part. Because it is a plain part, I end up calling it pars plana. Okay. Please remember, pars plana is relatively avascular. See, all these pieces of information we will be using as we move ahead. Yes, every piece of information on anatomy can become a question or a concept here, everybody. What do I mean to say when I say relatively avascular? Relatively basically means that the whole uvea, we are saying uvea, ciliary body is a part of uvea, uvea is vascular, but out of all the parts of uvea, pars plana is relatively avascular, the least vascular of all of the parts of the uvea. I hope I'm making myself pretty clear here. Now, the question that comes into mind is, we have these projections here, yes? These projections, both sides obviously. I'm showing it to you on one side. Do these projections or do these plicae have any name? Yes. Yes, I know a lot of you have already said the answer. These projections, because they are a part of ciliary body, get the name ciliary processes. Processes, finger-like projections, everybody, of ciliary body get the name ciliary processes. Why is it important to name this structure? Because this is a very important structure, everybody. I am writing ciliary processes secrete aqueous. Okay. There are two kinds of spaces in the eye which are filled by either aqueous or by vitreous. So the site of secretion of aqueous, everybody, aqueous is your ciliary processes. To remember it, I remember it as if I'm looking at a cow. Okay. A cow, I hope some of you may have milked a cow or at least seen a cow being milked, everybody. Yes. So a cow, beneath it has an udder, everybody. On the inferior surface has an udder. Udder has some projections in it. Yes. So we have to press those projections and we secrete milk. So draw the analogy from there. I don't know if it is a good or a bad analogy, but that's how I remember it, everybody. Yes. So I say when I see some projections hanging in the eye, everybody, I know they are going to secrete something, some liquid. And what is the liquid? The liquid is an aqua. Aqua means aqueous, everybody. So ciliary processes are the site of secretion of aqueous or aqueous humor in the eye. Done? Now, moving posteriorly, everybody, we have seen iris, we have seen ciliary body, the two parts of ciliary body. Now all the posterior part of the uvea must be my third structure, that is my choroid. So from here till here, everybody, what is the whole part? Choroid. Now, if we see carefully, choroid is that posterior part which is lined inside by retina. That means it tells us very important point about retina. The outermost layer is a complete layer. See, cornea anteriorly, sclera posteriorly. Yes. The middle layer is a complete layer. Iris anteriorly, intermediate ciliary body, posteriorly choroid. But retina is an incomplete layer. It is covering only the posterior part of the eye. Only the part which is actually choroid in the middle layer, that is being covered by the retina. So retina covers or lines, I can say, only the posterior part of eye. Okay. I hope we are clear about this basic anatomy of the eye in our 3D structure and then drawn on a 2D diagram for you. Yes. To complete it, everybody, if I say there are two spaces in the eyeball, obviously I will discuss them in detail later on, but the two spaces, everybody, all this space behind the lens or all this space in front of the lens. There are two spaces. The space behind the lens, everybody. This space behind the lens contains vitreous, as we had seen in our 3D model. And the space in front of the lens contains aqueous. Okay. So if you understand this diagram, if you understand the 3D model, I hope you will be clear with the anatomy. If not, everybody, I can tell you actually another way to remember it. Whenever you stand in front of a mirror, you can see your eye. I'm not talking about this eye. I'm talking about the literal anatomy of the eye. How, everybody? I hold my hands like this. When I hold my hands like this, what am I seeing? See, this is my iris. Can you see my iris? Can you see my iris? Can you see the hole between the iris? That is the pupil. Now behind the iris, can you see finger-like projections? That means this must be by ciliary processes. Yes? So if these are my ciliary processes, everybody, that means this part, everybody, is my pars plicata. Behind the pars plicata, where my shirt is not there, I see a plain area, everybody. That is my pars plana. Can you see, everybody? And this whole shirt is my posterior part. That is my choroid. As soon as I see this much, I know now that in front of the choroid, lining the inner side of the choroid must be my retina. Anterior there must be my cornea. And between the ciliary processes there must be some zonules, and here is my lens. Are you understanding what I'm trying to say? If you are able to see the eye with your hands, that means anatomy is pretty clear in your head, at least the organization of the eye. That is what is required in the beginning. If you are able to understand this much, then I hope you are good enough to go and read in detail about the parts of the eye. And that is what we are going to do now. We are going to start with our outermost layer. In our outermost layer, we are going to first start with cornea. Please remember, cornea is anterior and it is transparent. Yes? Let us begin the discussion of cornea, the layers, the parts, the anatomy of cornea in detail. Cornea. Okay, everybody? So, very basic fact. Number one, what is the blood supply of cornea? What is the blood supply of cornea? Yes, very good. The blood supply of cornea is that it has no blood supply, avascular. It has to be avascular to be transparent. If there is vascularity, there will be infiltration, inflammation. It will have chances of getting opaque. So it has to be avascular. We understand that. Apply the same concept when I teach you lens. Lens is also transparent and lens is also avascular. Remember this very basic fact. Okay, guys? Now, second point. What is the nerve supply of cornea? Nerve supply. When I'm saying nerve supply, no, don't tell me the peripheral nerve. Don't tell me the peripheral nerve. I want you to answer the central nerve. Which cranial nerve is the nerve supply for cornea? Okay? Cranial nerve supply for cornea. How to answer this? Think about it. There can be two types of nerve supply, motor or sensory. Now, cornea. Can cornea move? Is cornea a movable structure? Does cornea contain any muscle? No. So that means cornea need not have any motor supply. Cornea needs to have sensory nerve supply. Now think about a sensory nerve which supplies our face. Think about this, guys. See my hand. Look at my hand, guys. Yes, I hope you understand this. Trigeminal nerve. So the nerve supply is the fifth cranial nerve. Trigeminal nerve. Okay. Now, trigeminal nerve. Again, if you look at my face, everybody, there are three branches denoted by these three fingers. Number one, ophthalmic. Number two, maxillary, because it is the maxillary bone. And number three, mandibular, because it is the mandibular bone. Now, I hope there should be no confusion in your heads that which branch of the trigeminal nerve will supply my eye. Ophthalmic nerve. So, branch of trigeminal, ophthalmic nerve. At a lot of places denoted as fifth one, V1, first branch of the fifth nerve. Okay. Now, ophthalmic nerve has how many branches? Ophthalmic nerve again has three branches. What are the three branches of ophthalmic nerve? I am writing lacrimal, frontal, and nasociliary. These are the three branches of the ophthalmic nerve. What we want to know is, out of these three branches, which of the branch will supply my cornea? Lacrimal, frontal, nasociliary, everybody? Yes, everybody knows this. So the answer is nasociliary nerve. Okay. So a little bit of anatomy if you have forgotten it, guys, side by side. That ophthalmic nerve has three branches, and out of those three, nasociliary nerve supplies my cornea. Done, guys? So always I say, don't only remember the final peripheral nerve, always remember the whole. You don't know, examiner will ask you nasociliary or ophthalmic or trigeminal. Any level of the nerve supply can be asked, any branch can be asked. People who love mnemonics, this is an easy mnemonic to remember the nerve supply of the cornea. T for trigeminal, O for ophthalmic, N for nasociliary. So the mnemonic becomes TON, ton. Okay? I hope you understand it's a unit of weight, ton. Trigeminal, ophthalmic, nasociliary. Clear? Now, Now we understand from this fact that we have just now discussed that cornea has a sensory nerve supply. If cornea has a sensory nerve supply, that basically means cornea has what, everybody? Sensations. Yes? So my question, how to test corneal sensations? Very simple. All of you who have passed your ophthalmology postings must be jumping at the answer. All of you will be able to see this in my hand. Yes? What is this, guys? This is what is cotton wisp. It is nothing but diye ki batti. All of us light diyas at our home. Yes? Diye ke upar jo batti lagate hain, that in English is called as cotton wisp. So this has a projection to it. So how do we test corneal sensations? We take this cotton wisp and we touch it on the cornea. Yes? As soon as I touch it on the cornea, my cornea will feel some sensation, foreign body sensation. So it will try to remove this. So what will the eye do, everybody? As soon as I touch it, I blink. See, I inadvertently touched it. So as soon as I touched it, I blinked. Am I clear? So this is how you test corneal sensations. If a person has loss of corneal sensations, I will be able to rub this cotton wisp onto the eye. The patient will not blink. Yes, all of us have done this clinical simple test in our clinical postings, I hope, guys. So how to test corneal sensations? By eliciting corneal blink reflex. Please don't call it corneal reflex. Always remember corneal blink reflex. That your eye will blink whenever you do this testing. Corneal blink reflex using cotton wisp. Okay. What do we do in this? Very simple, guys. You touch the surface of cornea by cotton wisp. Nothing to explain, guys. I'm just writing. I hope you will understand yourself. Two scenarios can occur. Scenario number 1. When you touch the surface of the cornea, the patient will blink. If the patient blinks, what does it mean? Yes, it basically means that the corneal sensations are present and they are normal. The second patient, as I just explained to you, that I am touching the surface of the cornea by the cotton, but the patient is not blinking. That means that corneal sensations are either absent or reduced. Reduced basically means partially absent. So they may not be fully absent, guys. Or I can say, when the corneal sensations are absent, what can I call it? Absence of sensations is a whole subject of MBBS, guys, anesthesia. Yes? So I can simply call it corneal anesthesia. Corneal anesthesia. Okay, guys? So now this is an important word as far as our learning and our understanding is concerned. The examiners will invariably ask you what are the causes of corneal anesthesia, loss of corneal sensations. So that's what I am telling you now here. Causes of corneal anesthesia. This can be remembered by the help of a mnemonic, guys. The mnemonic goes like HDL acts. HDLACTS acts. HDL acts. HDL, I hope you understand, high density lipoprotein. So HDL acts. Now, H for herpes. The most important cause of corneal anesthesia. 99 out of 100 times when there is corneal anesthesia, you will think herpes simplex virus. D for diabetes. Diabetes.
Diabetes causes autonomic peripheral neuropathy. Peripheral neuropathy, nasociliary nerve will be paralyzed, will be affected. L for leprosy. Leprosy causes anesthetic skin patches everywhere, yes? So you understand that. A for acoustic neuroma. Okay? Acoustic neuroma. C for, T for, S for. C for should be very easy to remember, common sense. If I have applied a contact lens, yes guys? If I have applied a contact lens, I have created a barrier. I can't touch the cornea now, so I can't find out the anesthesia. So there is obviously corneal anesthesia. If I touch your contact lens, your cornea will not react. Okay? T for topical timolol. Beta blocker, guys. On long-term beta blocker use, specifically for glaucoma patients, it can lead to corneal anesthesia. Remember this as a cause of corneal anesthesia. Remember it as a side effect of timolol. Very commonly asked side effects of anti-glaucoma drugs. And as for surgical trauma, no brainer, guys. Okay? So these are our 7 important causes of a case of corneal anesthesia. Please remember by the mnemonic that we have given, HDLACTS. HDL acts. Again, I will re-emphasize, please do remember herpes, please do remember timolol. 2 of the commonly asked questions from this topic. Right, guys? So that's our corneal blink reflex to elicit corneal sensations and corneal anesthesia. Now, after we've done this much, guys, I want to go back to this word, reflex. As soon as I hear the word reflex, I get transported back to my first year. Physiology, anatomy. I get transported to the fact that we used to study about a reflex in our first year. A reflex is supposed to have 2 parts or 2 pathways or 2 arms. An afferent pathway and an efferent pathway. And that is the most likely question whenever the name of a reflex comes in. Okay? So my corneal blink reflex will have 2 parts. Afferent pathway and efferent pathway. Okay? So now the question, which nerve forms the afferent pathway? Which nerve forms the efferent pathway? For this, we need to basically understand what is an afferent pathway and what is an efferent pathway. Yes? I hope a lot of you already do that. Afferent pathway, A for aa raha hai. Yes? So when I touch the cornea feels sensations. And then these sensations are going to the brain. So brain mein aa raha hai. What is coming into the brain? Sensations. So sensations will have to be conveyed by a sensory nerve. So the afferent pathway has to be sensory. Am I clear? Then the brain will analyze, okay, something is touching my cornea. So I need now to remove that sensation. I need to do what everybody, blink, as we have just seen. So now my brain will send a nerve back to my eyelids. Yes? So the eyelids will have muscles. Muscles will move and I will blink. That means the nerve which is going back, the efferent pathway, has to be which nerve, everybody? Motor nerve. Okay? Very simple if you understand. I touch the cornea, sensation, sensory nerve go. Afferent pathway, motor nerve comes back, I blink. Efferent pathway. So sensory, afferent. We've already seen, guys, that the sensory nerve will have to be my 5th nerve or my trigeminal nerve. Okay? Because 5th nerve is the nerve supply of the cornea. What about the efferent pathway? Which will be the motor nerve? Motor nerve to my eyelids. My eyelids need to blink. Which nerve? Very good. 7th cranial nerve, facial nerve. To which muscle? 7th cranial nerve to which muscle, guys? LPS, no, LPS is supplied by 3rd nerve. To orbicularis oculi. So orbicularis oculi, efferent pathway, motor nerve, seventh nerve to orbicularis oculi. Okay, so now a slight clinical correlation here, guys. As soon as I've written seventh nerve or facial nerve, guys, I hope you understand that the clinical correlation is in cases of Bell's palsy. So, if a patient has seventh cranial nerve, Bell's palsy, which muscle is also paralyzed along with all the other facial muscles? Orbicularis oculi. So in Bell's palsy, there is orbicularis oculi palsy. Okay? Orbicularis oculi palsy will lead to what? What will be the clinical feature due to it? Orbicularis oculi palsy. A muscle in the eyelid is getting palsied. Are you saying ptosis? This is the usual answer that students think of. As soon as they hear eyelid, they only know one answer, ptosis, guys. But please think about it. What is the function of orbicularis oculi? Orbicularis oculi is helping in blinking. Blinking means basically closure of the eyelid. So orbicularis oculi function is blink, or I can say to close the eyelid. So basically on orbicularis oculi palsy, there will be inability to close the eye. Yes. So it will lead to inability to close eyelids. Or I can say inability to blink, which is known as, what is it known as? Lag ophthalmos. Okay, guys, do we understand this concept? Ptosis is drooping of the eyelid. Eyelid is itself going down. Here we are saying the opposite. Eyelid will not be able to go down. Eyelid will not be able to close. That is what we do in Bell's palsy. We ask the patient to close both the eyes. The side on which Bell's palsy is there, that eyelid will not be able to completely close. Lag ophthalmos. Am I clear, everybody? So, I hope you've been able to understand the nerve supply. TON, trigeminal ophthalmic nasociliary, the corneal blink reflex using cotton wisp, the causes of corneal anesthesia, and about the afferent-efferent pathway and the clinical correlation of the nerve. Right, guys? So that's about our nerve supply of the cornea. So going back, guys, we were discussing the anatomy of the cornea. We have discussed the blood supply. We have discussed the nerve supply. Now we need to discuss the layers of the cornea. So now we need to discuss layers of cornea. So guys, how many layers are there in cornea? 5 layers or 6 layers? That's the simple question. Yes, I hope all of you know that the new answer, it's actually not a new answer now. This answer changed in 2014. But still I will say a new answer is layers of cornea are 6 in number. Now, when we discuss the layers, we discuss or we learn them usually as number 1, number 2, number 3, number 4. But actually that is a very incorrect way of saying it. When you say layer number 1, which layer are you talking about? What do I mean to say? I'll just draw a rough cut section of the eye and I'll explain what I mean. Everybody, this is my cut section of the eye. You will be able to understand it, I hope. We'll be drawing this kind of a rough cut section various times. Because this is the first time we are drawing it, I'll just explain it to you. What have we drawn in this? Obviously, this is the lens. This is my optic nerve. Right, guys? What is this? The area of interest right now? Cornea. What is this? Sclera. This part which I've marked with a small line. limbus. This is iris and this is pupil. Okay, everybody? So this is the kind of cut section I'll keep on drawing throughout our lectures, guys. If you've drawn it, I'll focus on the area of interest, that is the cornea. Let's say my cornea is magnified here. Let's say this is my cornea, everybody. Okay? It is trying to denote that there are layers in the cornea. So, this layer, everybody. What will I say about this layer? That this layer is outside the eye or inside the eye. Yes, guys? You understand? This is the outer part of the eye. So, I will say this is the outer layer. But if I talk about this layer, guys, of the cornea, this will be the inner layer. So now, when I say layer number 1, which layer am I talking about? So when you learn it in numbers 1, 2, 3, 4, 5, 6, you don't know the orientation. So always remember the orientation in the whole body always has to be from anterior to posterior. That is how we learn everything. AP, antero, posterior. So now, which layer is anterior, which layer is posterior? Obviously, this layer is my anterior layer. And this layer, inner layer, everybody, this is my posterior. Throughout ophthalmology at least, I will be explaining everything from anterior to posterior. This is the way you will need to learn it so that you don't need to put your mind to it. Right? So when I say layers are 6, layer number 1, layer number 2, when I say layer number 1, I am talking about the anterior most layer. I am talking about the outermost layer. So when I talk about layer number 6, that itself means I am talking about the posterior most layer, which because of its virtue will be the innermost layer. Now, why go to such depths to understand such a simple concept? Everybody, here will also be your retina. Yes or no? Innermost layer will be present here. We will discuss later on. I am just drawing it to make you understand this concept. Just focus. Just listen to me for 2 minutes. This is my retina. Okay, everybody? Retina again has layers. Retina has 10 layers. Now, if I ask you about retina, this is which layer of retina? Anterior. This is which layer of retina? Posterior. Okay? Anterior, posterior always remain the same. But by virtue of the position of the retina, the anterior layer is now inside the eye. Or is it outside the eye? What can you see? Where is the anterior layer of the retina? Yes, obviously it is inside the eye. Whereas the posterior layer is outside the eye. So the anterior layer of retina is on the inner side. And the posterior layer is on the outer side. Yes? Now if you see carefully, this is opposite to cornea. My cornea is outside to inside. Layer number 1 to layer number 6, anterior to posterior. But my retina is inside to outside. You understand? So when we learn the layers, instead of the numbers, we should focus on anterior to posterior. So when I am discussing the layers of the cornea anterior to posterior, I am going outside to inside. When I am discussing the layers of the retina, I am going from inside to outside. Am I clear to everybody? So that is why always I say anterior to posterior. Now, let's start discussing everybody. Layer number 1. So, first layer of the cornea, guys. Outermost layer. Or I can say anterior layer. Outermost or anterior layer will always be epithelium. Epithelium. If you forget this, please remember epi. Epi is a Latin word which means out. That is a literal English to Latin conversion, guys. Epi means out. Okay, so epithelium itself is telling you that I am the outermost layer of the eyeball. Now, the question always is which type of epithelium, guys? So, epithelium always needs to be answered in 3 points. Number 1, non-keratinized. Number 2, stratified. And number 3, Which type of cell? Squamous. So the corneal epithelium is non-keratinized, stratified and squamous. Okay? Always, anywhere, epithelium, 3 points. Non-keratinized, it does not have keratinocytes, it is not like skin. Whenever we say keratinized, think about skin. Opaque, it is transparent. So keratinization will give some kind of opacity. Our cornea has to be transparent. Type of cell, you just need to learn it. Then comes the word stratification or stratified. What do you mean by this word? Stratified. Strata means layers. See again English, guys. Focus on the English. Strata means layers. Either an epithelium can be a single cell layered structure. If it is a single cell layered structure, like you have seen on the screen, you will call it non-stratified, pseudo-stratified. But if we see a layered epithelium, we call it stratified. So, how will it look like, everybody? Again, drawing a rough diagram, rough figure here. You can draw, everybody. Just feel free to complete your diagram. So guys, if you've completed the diagram, if you're with me, you will see that I have drawn a number of layers of cells showing strata or stratified. But what new are we seeing here is that these strata are further divided into 3 parts. So these strata are divided into superficial cells, middle cells and basal cells. Okay? Now, if you see carefully, what is the shape of the basal cells? They are tall. So these basal cells are columnar. Okay? Tall cells, columnar cells. If you see the superficial cells are flattened. Can you see, everybody? Flattened cells. So flattened cells, we all know, are called as squamous. Okay? So tall cells at the bottom, as they move up, they will keep getting flattened. So the middle cells are a transition zone. So they are neither tall nor flat. They are polygonal, right? They are in multiple shapes. They are getting compressed, you can say. Lambe se chote. They are getting compressed, guys. Okay? We understand this much? Now, please remember a very important fact about these basal columnar cells. These basal columnar cells have the ability of mitosis. They have the ability of mitosis. Now all of us know, everybody, what is mitosis? Mitosis is division. That means these cells can divide. When these cells are dividing, basically they are regenerating. So can I say, based on this single word, that because of the mitosis capability in the basal cells of the corneal epithelium, my corneal epithelium can regenerate. Corneal epithelium can regenerate. Please remember this point, guys. Okay? I hope it is self-explanatory. So, there is desquamation of the corneal epithelium. The superficial cells are desquamicized. So, the cells from the basal cells, they will divide and they will move up. Okay? So, the growth is from base to up. Regeneration. Done, guys? That's all about our topmost layer. The outermost layer, that is the corneal epithelium. Moving on to the second layer of the cornea. Very easy to learn the name if you don't remember it. The second alphabet in English is B. The second layer name starts from B. The name is Bowman's layer. Bowman's layer. Second alphabet B, second layer B for Bowman's layer. Two very important points about it. Number one, guys, I will again go back to the epithelial strata that I had just drawn. Everybody look at it. Normally, if I am talking about a structure anywhere in the body, what do we expect below the epithelium? Below the epithelium, we always expect a thin membrane. We expect a basement membrane. Yes? Do you understand this? Below an epithelium, we always expect a basement membrane. So ideally, going according to the fundamental that we know of about anatomy, Bowman's layer should be a basement membrane. Yes or no? That is the main point. Bowman's layer should be a basement membrane, but actually it is not. Okay? So this is a straightforward MCQ which can be asked, that Bowman's layer is not a true basement membrane. Bowman's layer is not a true basement membrane. How do we know this? How do we know this, that Bowman's layer is not a true basement membrane? Yes? So obviously we have done some staining. Bowman's layer is PAS negative. Normally basement membranes can be stained by PAS, periodic acid shift reagent, but Bowman's layer is PAS negative. PAS negative. That means does not stain with periodic acid shift reagent like true basement membranes. Okay? So true basement membranes should stain with PAS, but Bowman's layer does not stain with PAS, which tells us that this is not a true basement membrane. Okay, guys? So that's one important point about Bowman's layer. Please remember this. Second point is that Bowman's layer is acellular. Bowman's layer is acellular. It does not contain any cells. It is at last something like a basement membrane. It does not contain any cells. So now the question comes, what if I have corneal trauma? If I have very superficial trauma, only the epithelium will be lost? If only the epithelium is lost, it can regenerate. But if the trauma is destroying the epithelium as well as the Bowman's membrane, then what happens to the Bowman's membrane? Bowman's membrane is acellular. Can it regenerate? If it has no cells, can it regenerate? No. So it can not regenerate. Okay? If it cannot regenerate, it has been traumatized, it will have to heal. How will it heal? Yes, very good, by scar formation. Secondary intention healing, fibrosis leading to scar formation. So because it cannot heal, it cannot regenerate, rather, it heals by scar formation. Okay? Now I hope you understand why I have marked the word scar. My cornea is transparent. If the Bowman's membrane is destroyed, then there will be a scar. A scar basically means there will be a opacity in the cornea. Yes? So the opacity in the cornea, the opaque cornea will lead to some loss of vision. Yes? Cornea opaque, does not allow the light to go inside. So the patient will suffer from loss of vision. I hope I'm clear here. Very big difference between the fact that corneal epithelium can regenerate, whereas the Bowman's layer cannot regenerate. And because it cannot regenerate, healing leads to scar, scar leads to loss of vision. Now, we've got a word, corneal opacity. We've got a word, scar. So I'll just link another simple thing here and I will discuss the types of corneal opacity with you. So, types of corneal opacity. There are three types of corneal opacity, named as, number 1, nebula, number 2, macular, and number 3, leucomatous. Nebular corneal opacity, macular corneal opacity, and leucomatous corneal opacity. How to differentiate? Very simple, guys. To differentiate between these three, we can make a table here. Okay. So first of all, I am writing pupillary margin, iris structural details. Okay. I'm just completing the table, then I'll make you understand, guys. Just complete your table, guys. Basically, V is for visible and NV is for not visible. Simple. Okay. So what do I mean to say here? Nebular corneal opacity. That even though the cornea will be opaque, but this is a very faint opacity. This is a very faint opacity. That the opacity is so faint that you can still see the pupillary margin and the iris structure behind the cornea. Okay? But if I talk about leukomatous, leukomatous is a very dense opacity. Complete white opacity. Dense opacity or complete white. That means it will allow nothing to be visible behind it. Behind the patch of opacity, neither will you be able to see the pupillary margin, nor will you be able to see the iris details. Okay, guys? To understand this better, let's go on to this image. Right? Again, we have seen this image. We know that this is our cornea, guys. Okay? Behind the cornea, what can we see? We can see the iris and we can see this pupil. Yes? Why we can see this? Because the cornea is transparent. Now everybody, what I am trying to explain you here is, if there is an opacity on the cornea, let's say this is the opacity. This is a complete dense opacity. Okay? Now, if this is an opacity, obviously this opacity will be white in color. Are you able to see any of the pupillary margin here? Are you able to see any iris here? No. So that is what I say leukomatous, complete dense opacity behind which neither will you be able to see the pupillary margin. See, the rest of the pupillary margin you are able to see. This is the pupillary margin. Rest of the pupillary margin you are able to see. Rest of the iris you are able to see. But behind this opacity, neither are you able to see the pupillary margin, nor are you able to see the details of the iris tissue. Okay, everybody? So this is the basic differentiation between the three types of opacity. I hope you are clear about it. Okay? Going back, everybody. Nebular, macular, leukomatous. There is a question which the examiners ask. When you are a third year student in your Viva also, this is a question which is asked. And even in pre-PG, in your entrance examinations, this will be asked. Which type of corneal opacity causes maximum visual disturbance, or I can say distortion? Which type of corneal opacity out of the three, nebular, macular, leukomatous, causes the maximum visual distortion or disturbance? Okay? So, see, this is basically an English question. As soon as we read this question, we immediately start to think leukomatous. कि leukomatous is the most dense, तो सबसे ज़्यादा problem वही कर रहा है. See, but the point here in this question is, the examiner is not asking you which of the following causes maximum visual loss. Visual loss will be caused by leukomatous. They are asking you maximum visual disturbance or distortion, meaning that the patient can see, but the patient will complain of some problem in vision. The patient will say, I can see, but I can't see clearly. That is visual disturbance or distortion. Visual loss is different. I hope you understand the basic thing. So what is the answer to this question? The answer to this question is nebular. Against our expectations, Nebular, even though it is the faintest opacity, this is the opacity which causes maximum visual disturbance or distortion of vision. Yes, guys? Now you must be asking, why, sir? Why this? So let me explain you in a very simple form here, everybody. Okay? So this is my cornea, guys. Again, very simple rough diagram. I'm drawing two sets of diagrams. Okay. So let's say, first of all, I have an opacity which is very faint. So I'm trying to draw it by the yellow color to show the faintness of it. Okay. Secondly, I have an opacity which is completely dense. So to denote the density, I've drawn it with this dark color. Okay. So you understand here, this is what I'm talking about, a nebula. And this here I'm talking about a leucoma. Everybody. Now, because my opacity in a nebula is faint, it is actually allowing the light rays to go inside the eye. Yes or no? Yes. But this opacity is making my surface irregular. Corneal surface is irregular. The irregularity will lead to diffraction of light rays. Instead of traveling in a single direction, everybody, each light ray will be diffracted into various directions. Okay? So there will be multiple images, multiple light rays at multiple points which will form an image on the retina. So this diffraction, everybody, is leading to my visual disturbance. Whereas, you understand this? Yes, guys? Whereas if I talk about a leucoma, whatever light rays are falling on it, it is a complete dense opacity. There is no light going inside. Because the opacity is so dense that it is just absorbing all the light, it is not allowing anything to pass through. So there is visual loss. There is no visual disturbance because the light is not getting refracted at all. Refraction nahi ho raha. Refraction is not occurring. Instead, what is occurring, everybody? Complete loss of vision. Am I clear to everybody here? Yes? So that is your basic explanation of why nebula causes maximum visual distortion or disturbance. Okay? If we are clear about this, everybody, this is all about a second layer of the cornea, that is Bowman's layer. Again, please do remember two important points. Number one, it is not a true basement membrane. And number two, because it is acellular, it will form a scar, and we have discussed the scar here. Now, moving on, guys. I will move on to the third layer of the cornea. So the third layer of the cornea is stroma. Stroma. Stroma makes up 90% of total corneal thickness. Stroma makes up 90% of the total corneal thickness. Okay? Now, what does stroma contain? Everybody knows collagen fibers. Yes? So that's the question that the examiner is likely to ask you. What is the most common type of collagen? What is the most common type of collagen in the stroma? The answer is biochemistry, guys. Think about your biochemistry. Types of collagen. Type 1. Not type 4. Then collagen is in spaces or in fibers. Okay. Between the collagen fibers or fibrils, the spaces are filled with ground substance. We call them GAGs, glycosaminoglycans. So the next question, which becomes obvious, is what is the most common type of GAG? Heparin sulfate, keratin sulfate, chondroitin sulfate. Three things. Yes? Again, biochemistry, guys. For the corneal stroma, our answer is keratin sulfate. Our answer is keratin sulfate. Okay, guys? So very simple questions on stroma. Nothing fancy here, guys. I hope you will be able to remember this two most commons here. Moving forward, fourth layer of cornea. Fourth layer of cornea. Anybody? This is the new layer, guys, if you know the name. not Descemet's membrane. This is the new layer. This is what has made the layers 5 to 6. Yes, very good guys. The name is Dua's layer. Dua's layer. Dua कर रहे हैं भगवान से? No. So it is named after the Dr. Harminder Dua. This is something slightly to be proud of for Indians. Dr. Harminder Dua is a Indian medical graduate. He is now based abroad, but Dr. Harminder Dua was the doctor responsible behind its discovery, and that is why it has been termed as Dua's layer. Okay. What is the significance of Dua's layer, guys? The significance of Dua's layer is that Dua's layer is now considered as being the strongest corneal layer. Its thickness lies between 7 microns to 14 microns. Its thickness lies between 7 microns to 14 microns. Okay, everybody? Nothing much more about it. Just remember it is the strongest layer, so it will create a barrier to any kind of insult to the cornea. Next layer, guys. Layer number 5. Descemet's membrane. Descemet's membrane. Descemet's membrane is secreted continuously by the underlying endothelial cells. It is secreted continuously by the underlying corneal endothelial cells. Okay. Number 1, you know where the Descemet's membrane comes from. Endothelium secretes it. Number 2, if you focus on the English of this, it is secreted continuously throughout life. That means if Descemet's membrane due to some reason is destroyed, the endothelium will again secrete it. So I can say in another way, if I ask you, can Descemet's membrane regenerate? Yes, because it is being continuously secreted, I can say it can regenerate. Am I clear? So the difference between Bowman's membrane and Descemet's membrane, Bowman's membrane, as we saw, could not regenerate, but Descemet's membrane can regenerate. Okay, guys? Now, second important point about Descemet's membrane is its thickness increases throughout life. Its thickness increases throughout life. So when you're a child, your Descemet's membrane is usually around 3 microns, but when you're an adult, it is around 10 to 12 microns. So it is variable, and with age, the thickness of the Descemet's membrane will actually increase. Okay? Another important point about Descemet's membrane, guys. This is a question. I'm asking you a question. You can say, a lot of us know this already. Peripheral termination of Descemet's membrane is known as. Peripheral termination of Descemet's membrane is known as. Anybody? It is known as, yes guys, Schwalb's line. Schwalb's line. If you've ever studied the chapter glaucoma, guys, you would have come across this Schwalb's line somewhere. Yes, trabecular meshwork, Schwalb's line and such stuff. So obviously this is a straight one-liner question here, but I'll be using this word Schwalb's line. I will be using the concept of Schwalb's line when I discuss the chapter or when you are reading the lecture of glaucoma, guys. Okay, everybody? That's all about Descemet's membrane. Now the last layer of cornea, guys. Sixth layer. We can call it the innermost layer, or we can call it the posterior layer. Right, guys? So as discussed before, anterior to posterior. So we are not on the sixth layer, which is the posterior most, or which is the innermost layer of the cornea. Now, outside means epi, but inside will mean what, everybody? Endo. So the innermost layer is named endothelium. Okay? I hope nobody will have any problem in this nomenclature. Endo means inside. Now, endothelium, everybody. First of all, we should know that this is a single cell layer. Unlike the epithelium was stratified. Endothelium is a single cell layer. Then it has a very important function, you can say, of metabolism. So if somebody asks you which is the metabolically active layer of the cornea, the answer will be endothelium. Okay, guys? Then thirdly, about endothelium, what we should know is that endothelium helps in maintaining corneal transparency. Corneal transparency, cornea needs to remain transparent. So there have to be a lot of factors which help in that. Okay? How? That's what we are seeing. So helps to maintain corneal transparency. By two things, everybody. Number one, it has an active sodium, potassium, ATPase pump to maintain corneal dehydration. An active sodium potassium ATPase pump which keeps on pumping fluid outside the cornea, okay, away from the cornea, thus maintaining corneal dehydration. If the cornea ever will become edematous, it will itself become hazy. So corneal dehydration needs to be maintained. Secondly, by tight junctions between adjacent endothelial cells. Tight junctions between adjacent endothelial cells. So I hope we understand the concept of tight junctions. Yes? If there are two cells, if those two cells are kind of in adhesion with each other, tight junctions, adhesion though is the wrong word, zona occludens, okay? So they are so near to each other that they are forming an impermeable barrier. So they are not allowing fluid to travel from one place to another. The same fundamental is present in the corneal endothelial cells, which does not allow the fluid to enter the cornea. If you are wondering how, again I will draw a diagram, a cut section, and I'll try to explain. Everybody, see, cornea, limbus, sclera, iris, lens. Okay? Same cut section diagram, guys. I'll just magnify the cornea again. So this becomes our endothelium. Now, what we know, everybody? We already know that in front of the lens, or we should know rather, that in front of the lens, in all this space, is present a fluid. What is the name of the fluid, everybody? Aqueous. Aqueous. Aqueous is derived from the word aqua. Aqua literally means water. Yes, fluid. So this fluid, like all the fluids, wants to flow. So aqueous wants to flow in all the directions. Left, right, behind and forward. Aqueous wants to flow forward. When aqueous wants to flow forward, it basically wants to enter my cornea. But it does not enter my cornea. It is not able to enter my cornea. Why, everybody? Because of my endothelial cells, which are forming a barrier. Because of the zona occludens, zona adherens, tight junctions. Okay, everybody? So they are forming a barrier. It's like a dam. It is not allowing water to flow from one side to another side. We already understand that if there is a disease which will damage my endothelium. If my endothelium cells gets damaged, everybody, let's say these cells get damaged. Okay, that means my endothelium is broken. If my endothelium is broken, this fluid will now be able to enter inside my cornea. It will cause edematous cornea. Edema, apart from increasing the thickness, obviously it will lead to haziness. Yes, so thus there will be loss of corneal transparency. I hope we understand this very simple concept here, everybody. So two mechanisms of maintaining corneal transparency in the endothelium. One is the active pump and second is the tight junctions between endothelial cells. So we understand that these endothelial cells and their organization is an important thing. So the question is, what is the normal endothelial cell count? Normal endothelial cell count. Normally in the endothelium we have around 2400 to 3000 cells per millimeter square. 2400 to 3000 cells per millimeter square. Okay. If the endothelial cells are less than 2400 but more than 500 per millimeter square, less than 2400 but more than 500 per millimeter square, then what occurs is cornea adapts by polymegathism and polymorphism. Cornea adapts by polymegathism and polymorphism. What do we understand by this word, everybody? Again, English. Polymega. Poly means multiple. Mega means increase in size. So the cells which are normal, which are surrounding the defective area, multiple cells will become large in size. They will become large so that they are able to plug this gap. Polymorph. Polymorph means, morph means to change the shape. Poly means again multiple. So multiple cells will change their shape and their size, polymorphism and megathism, and they will plug this gap. Okay, everybody? So till my critical level, that is 500 cells per millimeter square, the cornea keeps on adapting. It is still able to maintain the corneal transparency. Okay, everybody? But if the cell count becomes less than 500 per millimeter square, then occurs corneal decompensation. The cornea is not able to compensate anymore for the loss. Okay, everybody? So it is not able to maintain its function. The endothelium is not able to maintain its function. So corneal decompensation it is called as, and in this what will occur, everybody? Hazy, edematous cornea. Okay? So I hope we are clear about these values, everybody. What is normal, then what is the range of adaptation or compensation, and then less than 500, there will be decompensation. There should be no doubt about all of this, everybody. Now, if you are listening to me carefully, I am saying all these questions or all these fundamentals, all these are based on the number of cells. So basically, as a clinician, we should be able to count the number of cells to be able to find out which stage my cornea is in. Yes? So which investigation is done? That's the question. Which investigation is done for endothelial cell count? Okay. Now guys, I know all of us can learn a lot of stuff. But if you take your common sense along with you everywhere, then you will benefit. What is the common sense here? Endothelial cells, whatever cells, can you see them by your naked eye? No. That means you need to see the cells by some instrument. How do we see cells, eosinophils, basophils, our whole class 12th biology, our anatomy, our physiology? We have used microscopes. So again, it is very evident that if we need to see something which is cellular in nature, we need to magnify. So we need a microscope. So that is my common sense, that I will need a microscope. The only thing that I will now need to remember is that there is a special type of microscope. Okay. So if I was attempting an MCQ, if I didn't know this answer, I will search for the word microscope in one of the options. Maybe it will help me to answer the question just by common sense, guys. Okay. The name is specular microscopy. So the investigation is called as specular microscopy. Okay, everybody, done? I hope you will be able to remember this name, specular. Basically, this is microscopy done in a live tissue. I'm not taking out my endothelium and then making a slide out of it. I have to count the endothelial cells in the live tissue, right, guys? So that's it about the anatomy of the cornea, guys. I hope we've been able to understand 6 layers. Number 1, epithelium. Number 2, Bowman's membrane. B, second letter, Bowman's. Number 3, stroma. Number 4, duas. Number 5, descemetes. And number 6, endothelium. Right, guys? We have discussed the blood supply, we have discussed the nerve supply, we have discussed the layers of the cornea. I hope you understand that along with the anatomy, I have also discussed somewhere the biochemistry, the clinical correlations, corneal opacity, what will happen in each type of corneal opacity, why is Bowman's membrane or Bowman's layer pass negative, right? So I have tried to discuss clinical correlations along with it. That is the way I want us to study, to be able to correlate everything. Now, after we have finished this much in cornea, there is just one simple question that is asked, has been asked previously a lot of times, which I will discuss with you, which is in continuation actually to what we were discussing in endothelium. Factors which help to maintain corneal transparency. Okay? Factors which help to maintain corneal transparency. So let's see, everybody. First factor. The first factor is actually the tear film. The tear film present over the cornea and the conjunctiva both keeps the surface of the eye moist and thus basically helps in the light traveling in a straight line. Secondly, the second is avascularity of cornea. Again, as mentioned before, an avascular cornea, no blood vessel, no infiltration, no inflammation, helps in maintaining the corneal transparency. Third important factor, guys. Third important factor is the collagen fibers in stroma. The collagen fibers in stroma actually also help to maintain the transparency by being uniform in diameter. All the collagen fibrils are uniform in diameter, and because of equal distance between all collagen fibrils, that is less than half wavelength of light. Okay? I hope you understand a little bit of physics. Two lines of collagen fibrils. The distance between two collagen fibrils will be lesser than half of the wavelength of light. So in case two wavelengths of light or two beams of light, they interfere with each other, they will cancel each other out by destructive interference. Constructive interference where they add, destructive interference where they minus each other. So because the wavelength is less than half, destructive interference will lead to cancelling of any scattering of light. Okay, guys? Then The fourth factor is, as we just now discussed, the corneal dehydration maintained by endothelium. The corneal dehydration, which is maintained by the endothelium, as we have discussed in detail, the sodium potassium ATPase pump and the tight junctions between endothelial cells. The next factor is normal intraocular pressure. Normal IOP, normal intraocular pressure. If the IOP is high, it can break the tight junctions. Just again, if the IOP is high, just again think of it as a dam being broken by very high pressure of water on one side of it. So if the aqueous pressure will get high, it will break the tight junctions. Okay? Then the last important factor in maintaining the corneal transparency is crystalline proteins in corneal stroma. Crystallines or crystalline proteins in the corneal stroma, which reduce the backscatter of light. Okay? Which reduce the backscatter. After the light has left the cornea, it can come backscatter. Okay? So it reduces this, the crystalline proteins in the corneal stroma. So these are 6 important factors maintaining corneal transparency. The important one being endothelium, because it is primarily maintaining the corneal dehydration. Right, guys? So that's all about our discussion on anatomy of the cornea. I hope you understand this. I hope you use these basics when we do study the diseases, the pathologies in cornea. Right? So we are discussing the outer layer, guys. Outer layer, number 1 part, cornea, done. Now we move on to the second part of the outermost layer, and that is our sclera. Okay? So everybody, let's start with sclera.